I'd like to introduce Lawrence Lister. He's the Director of Biocompatibility at Toxikon, and he's going to be speaking on the issue of biocompatibility today.
Thank you. I'm so sorry I'm late. It's just terrible, terrible traffic. Today's presentation is going to be a little different than maybe what you're used to. I'm not going to regurgitate guidelines to you. I'm going to share my experiences of about 27 years in what happens when a biocompatibility test fails. So your day is about to change. Someone, like myself, has the unpleasant task of having to break the news to you that one of your tests may have failed. And most people don't like being the bearer of bad news. And no one does biocompatibility testing hoping that they get a failure. And so someone like myself knows that there's going to be predictable reactions to this news. And I have to say, don't shoot the messenger. Sigmund Freud felt that that was a self-defense mechanism, and in shooting the messenger, you were removing the source of the bad news, and the bad news would go away. So, a test has failed. So what we want to do is get into a little psychology first, and the reason is because your reactions are important. How you react to this will speed you through the process. So, the Kubler-Ross grief cycle, many may know it as the 5 stages of grief or the 5 stages of dying. It's actually 7 stages, but they are overlaps. Grief can exist without death. Think of it in a different term. It's 5 stages of devastating news. And it's very real and it's very palpable. If you are a HR person, you're probably not in the room, but if you are in a position where you've had to terminate someone's employment, you have actually seen this unfold right before your very eyes. And the first step is denial. You'll inform the person they have lost their job, and they're incredulous at first. They just can't believe that what you're saying and what they're hearing. Then they're going to get angry, and they're going to fight for their very existence. Then they're going to bargain. They're going to say, well, I promise I'll do better. And, you know, if I only knew something was wrong, and maybe they had warnings, then the room will get quiet. And this is where depression sets in. And eventually, they will actually accept it and ask where to sign next. So isn't this about biocompatibility testing? Yes, but it's about dealing with the failures. So you will go through the biocompatibility failure cycle. And you'll hit denial, not my product. This doesn't make sense to me because it passed one test and it should have passed all the tests. And why only one extract? You did 2 extracts, both should fail, right? And this actually is a result of not having a full understanding of biocompatibility. The next stage will be anger. You must have done something wrong. I shouldn't even have to do the test, which actually sort of overlooks the fact you had a failure and this is why you have to do the test. Or what we'll hear is that this has been historically used. Well, it's not about actually materials anymore. It's about what your processes and the materials do to each other. Then the bargaining will happen. Do you know how important this product is to my company? Do you know how much it cost me to make these products? And finally, do you know how much money I spend with your laboratory trying to coerce the contract lab to maybe view it in a different manner? Depression will set in. And this will be the end of the phone call. This is actually how the phone call can end. Because someone like on my end of that phone call, we want to stay there and answer the questions while you're firing off the questions. We're not just going to hang up on you, but the phone call will end as you start to absorb the news. You're going to worry about your company's health, and you're going to worry about your job security. So these are the things that's going to be running through your head. And then finally, there's acceptance. And what I want to say, and the same as the employee, don't get stuck in angry denial. Right? You need to get to acceptance as fast as possible. Only in acceptance can you troubleshoot and move forward. I hate when I get ahead of myself. So advice, spread the word. Tell everybody in your company who needs to know, because you don't need their angry denial getting in the way of your troubleshooting, because you have a lot to do. There is a difference between the doctor telling you that your spouse has cancer and him saying, despite everything we've done, the first one is typically met with, what are our options? And that's really where we are here. What are our options to deal with this failed biocompatibility test? So the first step would be, you have to ask some questions of the lab. What test or what tests did it fail? How badly did it fail? How did it fail that particular test? And I'm going to talk more about these points in subsequent slides. And how confident is the lab in the failure? Then it's time to ask some questions of yourself. Is this failure a crisis? It may not be a crisis. You may have a failed cytotox and your product is an antimicrobial. It's not a crisis. It's actually functioning the way it should. And also, what was sent to be tested? This is a huge question, and you might not actually think about it, but I have in my experience, the sponsor has not actually known what they had sent to be tested. They delegated that out to someone else. Time to ask some collective questions. This is another call or email exchange with the lab. What could have been done differently? Will doing it differently make a difference? And will doing it differently make it valid? So we get into the what test did it fail and what test did it pass. So in a standard biocompatibility evaluation, you're looking at around 8 different testing categories. They're called endpoints now. They used to be testing categories, but with recent changes within the industry, they're called endpoints, because you don't necessarily have to test to these different endpoints. But something could fail cytotoxicity, or something could fail acute systemic toxicity and pass cytotoxicity, or something could fail both. So what you need to do is talk to a real subject matter expert. No offense to consultants in the crowd, but not every consultant actually knows what biocompatibility is. Just because someone may have a DABT in toxicology, that does not mean that they're familiar with biocompatibility testing. And typically people believe that if it passes cytotox, that was all it needed to do. It would pass everything else. And in reality, that's not true. How is that not true? Well, if you think about drugs, and maybe your device doesn't have a drug on it, but a drug is a chemical, and chemicals are in devices. A drug is a chemical that has an intended purpose. And something may pass cytotoxicity because it doesn't degrade the cell, but it may fail the acute systemic toxicity because of the effect it actually has. Maybe it's an anticoagulant, and that's not going to kill a mouse fibroblast, but may cause the mice to actually internally bleed. How badly did it fail the test? Well, this does matter. Inherently sensitive biocompatibility tests will have will have criteria within it for retesting. So what are the results within the margin of error? And when I say margin of error, that doesn't necessarily pertain to biocompatibility, but I know most people do know what margin of error is. And what I'm getting at is, if there's a threshold of 1.0 as the pass-fail criteria, and you're at 0.9, okay, that's passing, but it's really close to failing, and that's a concern. 1.1, that's failing, but it's just failing. Typically in biocompatibility, things either pass with flying colors or go down in flames. There's very few that are actually within that margin of error. And an example is the rabbit pyrogen test. In the initial test, there's 3 rabbits, and if any animal gets over a 0.5 increase in temperature, it does not pass. That does not mean it fails yet, but it means it does not pass. It then kicks it into the retest criteria, and 5 more animals would be done. No more than 3 can get a 0.5, which that then includes the all original first 3 and none of the second 5. None of the second 5 can have an increase of 0.5, and the cumulative temperature of all 8 animals can't exceed 3.3. So it is possible for the first 3 rabbits to fail the retest criteria. And that is where, does it fall in the margin of error? Can it qualify for a retest? And in that example, that exceeds the retest capability. And then what happens if you do get a pass? So you do the test the second time and it passes. Well, FDA is not going to want to see a pass and a fail. What needs to happen is that original failure needs to be identified, the reason for that. And subsequent questions, that's part of the examination of the failure. How did it fail is an important question. Were there single failures versus multiple failures? When there are multiple failures, there's typically a link, and that link is going to be the cause, and that cause is the answer, typically. One thing is pH. pH extremes in biocompatibility testing will cause failures. pH is not something that we're allowed to really address because in clinical use, your clinician, your patient isn't going to have the ability to adjust the pH. So that's not typical for a biocomp study to initiate pH measurements or pH adjustments. And another thing is tonicity. What's meant by that? Water, for example, is really not biocompatible. You might think so, but when it comes in contact with cells, through osmosis, it ruptures those cells. It just rushes in. If you were to inject a high volume of water into a mouse, the mouse will die. It is a positive control on the hemolysis test. So in tonicity, it could possibly either draw water out of cells and cause some cytotoxicity there, or it could force water into the cells and cause the lysis of the cells. How confident is the lab in the failure? Now, I say be careful here, because if you ask it the wrong way, you're insulting them, and their desire to help you may wane. But ask the question, how many of these tests do they perform? Is this a one-off for them? If this is a one-off for them, maybe they did something wrong. If this is actually a routine biocomp test, let me tell you that what we do is we batch to take advantage of economy of scale. Typically, there's 15 tests being run at any given time. Controls are being shared. Whether it's cytotoxicity or acute systemic toxicity in mice, controls are being shared to minimize the amount of work. Every test requires a control. But we can do it once and apply that across 12, 15 tests. So how many do they perform is important. Was this failure one of few, or was it one of many? Because if it was one of many, then there's low confidence. If there's many failures that day, there's low confidence in the test. And the lab itself should have informed you that they actually suspect the results. If it's one of few or the only one that failed, then the confidence is going to be extremely high. If the controls worked the way they were supposed to, that means the environment was correct. That means the processes were correct. That means all the conditions were correct. And if you are the only failure, unfortunately, it's got something to do with your product. Still not saying that your product is not biocompatible, but what I'm saying is that there's something, maybe the tests weren't appropriate for that. Is the crisis a failure? So I already gave an example of that, and that is that the antimicrobials are on the market. Chlorhexadine's on the market, antimicrobial catheters, silver is cytotoxic. All these products they did fail biocompatibility tests. They failed the cytotoxicity, but they passed acute systemic toxicity. And so it's not any single failure is going to throw you into a head spin. The biocompatibility endpoints are unique to each category. So as I gave the example earlier, the cytotoxicity is maybe it's cytotoxic because it's killing the cells, or maybe it's systemic toxic because it has a pharmacodynamic effect. Sensitization and irritation both look at redness and swelling, but one's caused by an irritation response, one's caused by an allergic response. So that there are different causes that are causing these effects that we see. So you have to look at the grand scheme of things. What is the intended use of the product? Goes a long way. A lot of times when we're having these conference calls and we find out that it's an antimicrobial catheter, then we go, well, there you go, you're good. Another example, though, is absorbable sutures. An absorbable suture, if the wrong controls weren't used, if the wrong controls were used, if the lab was not informed or you didn't provide the appropriate control, under a microscope, that is going to have increased cellular activity, and it's going to look non-biocompatible when compared to an inert plastic. So that's an example of where it's intended to degrade, and the body's doing that, but you're comparing it to an unfair standard. And maybe the test method is just too rigorous. A topical ointment could be, if it was dosed in the eye, that's not appropriate, and that's a much more stringent method. Years ago, that was required, just so that we knew that if stuff got splashed in your eye, what to expect. But like wound healing products, very typically have to be tested via the intracutaneous, which is an intradermal injection. And wound healing products typically have some effect, some intended effect, and they don't do very well on the intracutaneous. But FDA feels that the intact dermal application is not appropriate as well, because it's being put into a wound, and healthy skin is not a good analogy. So maybe that test method has to be modified to maybe create an abrasion. What was tested? So basically, there's this big shift in the biocompatibility realm to get away from the checkbox mentality. And that actually, I have to admit, exists, and it still exists. And even though they're trying to change that, they still require you to address each endpoint. So although they say it's not checkbox mentality, they are regulators, regulators want to see that you have either tested to, or you have data from previous testing to those endpoints. Some people don't take biocompatibility testing serious. You know, what was tested, I believe this slide might be out of order here. What was tested in an investigation years ago, we're talking to the sponsor, and the sponsor looks internally, and what was sent to us to be tested was not the final finished sterilized device, that's what's supposed to be tested. It was engineering rejects. It was, well, we can't use this, it's ugly or it's defective, send that for Biocomp. And it was literally sitting on someone's shelf or something, and someone packaged it up and sent it to us. And it failed some Biocomp tests. And so be aware of what was tested. Did you delegate that task? It's really important. When you get that bad news and you start worrying about your job and everything else, that's really, you need to think about that proactively. What could have been done differently? So this is where we get into the different changes. The extract ratio. In biocompatibility, we have to use a 3 centimeter or 6 centimeter ratio. Weight is also an option, but you have to justify that doing it by weight uses more than if you were doing it by surface area. So that is something that can be adjusted. The extraction temperature should be the highest that doesn't deform or degrade the test article. So for most polymers, that's going to be 70 degrees. But maybe in this instance, 70 degrees is pushing that limit. Maybe it should be dropped down to 50 degrees Celsius. If there is a biologic on it that denatures above body temperature, maybe 37 degrees. 37 degrees actually needs to be justified, but if you have a coating on there that's going to degrade, well, there's your justification. What extraction vehicles were used? The common extraction vehicles are a vegetable oil. We use cottonseed oil and saline. But there are alternative vehicles that can be used, such as ethanol, polyethylene glycol, or DMSO, and they can have effects in of themselves. And so, did you use something out of the normal for that test? What were the proper controls used? A pH elevated test, we're dealing with one right now, the product actually brings the pH up to around 10. And we're not typically allowed to adjust the pH. FDA pushes back on that. So we're going to have to take a test article that we know the pH is 10, alkaline, and inject it into the dermis of rabbits, and we can predict that it's going to fail. But how do we get around that? Well, we can get around that by adjusting, giving another set of controls. The standard control will be a pH of 7, but then let's use a blank control at a pH of 10. So we have two comparisons. So there is an opportunity there to rectify a failure. Pre-swell or rehydrate. So I talked earlier about tonicity. Maybe it's drawing all the water out of the cells. Well, there's a way that can be addressed, and that is by rehydrating the product. Let's get it to its absorbing capacity before we bring it into the test system. What parts were tested? So maybe there's electronics. In order to create these extracts, we have to cut the products up and submerge them in these vehicles. And what happens when you have wires or solder or other products in and around the vehicle? Copper is not biocompatible. Tin is not biocompatible. Zinc is not biocompatible. And those can migrate out in. So were those part of that extract? That is something to address. Were internal parts exposed? Also the same thing, is there coatings and external parts earlier were, Karen clamps and covers, and the packaging should not be tested. A competent biocompatibility lab will remove those. But as I said, if is this a one-off for them? Because it may seem simple to run one of these labs, but it's actually, there's a lot to be considered. pH adjustment, I already gave that example. Centrifugation comes with a lot of having to justify that, and it's really not a lot of success rate in that. But there are ways around that I'll talk on a future slide. Changing the dose route. So let's say we have particulates in the extract. We can change the dose route in the acute systemic, which is an IV administration, but if there's particulates, we could have an ischemic event. And we don't want to have mechanical reasons for clinical observations of toxicity, that does not let us know if it's actually test article related. It could be related to the particles and a mechanical process. But when we change the dose route, we could also be changing the test method. So in the acute systemic, the acute systemic, we would go from an IV to an intraperitoneal into the abdominal cavity for an injection. That's still the same test, but when I talked earlier about an eye irritation versus a skin irritation, those are actually different tests. So changing that dose route might be appropriate because it's more appropriate for the exposure of that test article, but it is changing the test method. Will doing it differently make a difference? Well, this is a case-by-case situation, and this depends on the answers of all the previous questions. Some products are just not biocompatibility testing friendly. Hydrogels very frequently are going to fail biocompatibility. They're so hygroscopic, they draw out so much water out of the test system that it's very hard to conduct the tests. There's ways around that by getting into a clinically relevant dose. Clinical relevance in the biocompatibility sphere doesn't often play a big role. There's set standards, and you have to sort of fit within those standards, and clinical relevance isn't typical in there, but when you're dealing with a failure, it might be the only alternative that you have. So adjustments can be made to the plan. We're going to call them adjustments because you should be starting out with a plan, and as with any plan, you don't scrap the plan, you make adjustments to it. Some adjustments are going to need justification, some adjustments don't need justification, and some adjustments won't be able to be justified at all. And then maybe adding additional evaluations. So we do an intradermal injection, and we're looking for redness and swelling. And 2 days later, it's still swelling. And we find out, because we didn't know in advance, that it's a dermal filler. And so it's appearing as a swelling, but it's actually, here's another example of it's doing what it's supposed to do. It's supposed to fill a void, and it's showing up as swelling. In order to make that failure go away, you have to prove that it isn't swelling. And how would you do that? By doing pathology on the test sites and show that there's foreign matter still present and not inflammation. So will doing it differently be valid? Well, that's what it's all about. Now, the FDA has recognized consensus standards, and you can go on to, it's an access.gov, that's the trailing end. You can just Google recognized consensus standards, and then there's a search term. You're going to go to biocompatibility, and you really want to then select on ISO. Don't bother going through the ASTM methods and everything else, because the FDA has published a couple times the use of ISO 1093-1. So when you're doing a 510K or a PMA, you're going to have to do biocompatibility. And the FDA had published this most recent version in 2016, and they're telling you that they want you to follow the ISO 10993 series. It starts with one, and that gives you the framework, but then there is 20 some odd chapters following that discuss each specific category within the grid that I had shown earlier. So on these recognized consensus standards, you can pull it up and it'll say ISO 1093-6. And then there will be the extent of the recognition. How much of that do they recognize? Because in some of these standards, the FDA will say, we recognize the entire standard, or we recognize the entire standard except for, and then they will throw out some standards. Maybe about a year ago, ISO 1093-10 actually is the irritation standard. And there are standards in there for rectal irritation, vaginal and penile irritation. And about a year ago, the FDA said they recognize the entire standard except for those. And if you wanted to do those to consult with them first. The fact that they were saying they don't recognize it might be an indication that you didn't have to do it. But now it says the entire standard again. But going outside the recognized consensus standards is coloring outside the lines. And coloring outside the lines is going to equal a deficiency letter. So what is inside the lines? Removing the non-patient contacting components, what's inside the lines do not need to be justified. So removing the carrying clamps and the slider clamps and the dust covers, those components aren't going to need justification. In fact, they shouldn't have been tested in the first place if they were. But, you know, depending on the plan, maybe the lab was directed to do it, or maybe they didn't know any better. Maybe it was a part that they weren't aware of that was removable. But removing non-patient components can help. More appropriate controls. In the example of the absorbable, I'm going to say a bone screw, an absorbable bone screw, PGLA. When we compare that to high-density polyethylene, it's going to fail. But a more appropriate would be some PGLA that's already marketed. That will have because it's already marketed, that becomes the predicate, and the comparison is a more fair comparison. And you only have to show substantial equivalence, not necessarily better. Pre-swelling or rehydrating doesn't need justification. The standards actually, and this is the thing with the recognized consensus standard, is Part 12, which just tells us how to prepare the product for testing, is completely recognized. And within Part 12, it says for absorbent products, you may change the ratio and you may get it to its absorbent capacity before extracting. And so if you were looking for a justification, you simply only have to point to Part 12 says it's okay. And that usually makes the deficiency go away. Fine-tuning the surface area calculations is another thing. So if you used a 3 centimeter squared ratio, or a 6 centimeter squared ratio, what was calculated? Now, the thing is, you don't have to calculate intricate surfaces. Or, for example, a foam. If it's treated as a slab, then that's 3 centimeters squared, and then we adjust the volume of the extract. But when you actually think of the foam, it's very porous. You could probably do a much finer tune on the surface area calculations and bring that volume of vehicle up. It's not, I don't want to say the term diluting the extract, it's just making the extract more appropriate. So what straddles the lines? Modifying the dosing route. This straddles the lines, and a lot of times, and this is also linked with the test method, is the test method appropriate? Is dosing the mice by IP instead of IV, that may need justification, and a toxicologist or a biocompatibility expert or the lab can help you dealing with the regulator in that a toxic compound, whether injected intravenously or intraperitoneally, is still toxic. You're still going to see reactions. It's just going to take a little longer, as opposed to maybe instantaneous. It might take 30 seconds. But there is rapid absorption within the abdominal cavity, and those particulates are injected into the abdominal cavity, and if they are actually toxic particulates, the body is absorbing the toxins off that. Changing the test method, a lot of things fail cytotoxicity. It's just the nature of that test. It's very sensitive. It's a screening study. And what people do, a lot of times they may change the test method to the agar diffusion, which is not an appropriate test method. And so that really straddles the line, because if you change from the the MEM elution to the agar diffusion, regulators actually can recognize what you're doing. And if you didn't provide them the failing results from the MEM, they're gonna force you to go back and do an MEM. And then you're sort of looking a little like disingenuous because you had results that you didn't provide them. So you were suppressing negative results. 37-degree extract straddles the line as well. The use of ISO 1093 that I mentioned earlier, FDA says that 37 degrees for 72 hours is likely not appropriate for anything that is mucosal contacting, externally communicating, or permanent implant or breach or compromise. So that actually is every category in the testing categories except for intact skin. So 37 degrees straddles the line. You can justify it if you have a compound in there that you know is going to degrade at temperatures beyond 37. Filtering extracts. If you notice, that is like barely straddling the lines. I put it there because there is a way to possibly not filter the extract, but to make so much extract that you can sample in and around the particulates. You would filter because you have suspension of compound, but maybe there's a layer of saline or cottonseed oil that is injectable. Every test has a specific volume requirement, and it is possible that we just create enough extract that top layer gives us the volume we need. Going from 6 centimeters per 6 centimeters squared per ml to 3 centimeters per ml, that does straddle the lines. And why do I say that? Well, the standard says that if it is less than half a millimeter in thickness, that it is to be 6 centimeters per ml. And if it's greater than half a millimeter in thickness, that it is to be at 3 centimeters per ml. But let's say it was done at 6 centimeters per ml. What I've seen with the FDA anyways is that they are asking for something between 3 and 6. They hold the line in a lot of aspects, but in that one, they typically want to see something between 3 and 6. So if you did it at 6, maybe doing it at 3, which is going to then cut the extract in half, or the amount of test article present in that same amount of volume. So what is outside the lines? pH adjustment. It used to be that we could adjust the pH. I actually have 2 situations dealing with this right now where, and these products are intended to drop the pH. One raises it, one drops it. One is a hemostatic agent, and it's becoming acidic in an attempt to cause the blood vessels to close. And another is a nanomaterial that's going to be loaded with a chemotherapy warhead, and basically cytotoxicity is okay, but that's bringing the pH up to 10. And the FDA is making us go and retest these without adjusting the pH, without filtering them. And how do we get there? Because we do have regulators that see that failure and try to explain it away as not a big deal. It's a chemotherapy agent. The chemotherapy agent is cytotoxic. The device that it's bound to is cytotoxic, but that's what we want it to do. Extract ratios below 3 centimeters squared. As I said, where we're straddling the line previously, if you drop down below 3 centimeters squared, it's not gonna work for you. Centrifugation. Once again, by centrifuging, you are removing possible toxins out of the extract. There are, maybe allowing it to settle. Most things, they're sitting at a slow agitation for 72 hours. They're not going to, centrifuging isn't really going to typically help you out anyways. Diluting the extracts is a deal breaker. It has been suggested. The only time that diluting the extracts should be done is in the investigation of a failed cytotoxicity. What they like to see is that you then test serial dilutions of that initially failed extract until you find out at what point it's not cytotoxic. But starting off by diluting extracts is your testing won't be accepted. And bulking up the test article with unnecessary parts. Now, a good example of this is a permanent implant, whether it's a drug-eluting stent or a bone screw. It's brought in through a catheter or some other device. The device is going to be much bigger than that permanent implant. And if you extract them together, you are essentially taking the least invasive part of the product that's going to be in the body for 30 minutes to maybe 4 hours, and bulking up the extract of the permanent implant by including those materials. And that is also going to get you a rejection. So consider your counsel. What is someone's actual experience? Are they trying to steer you up and over the mountain, or are they trying to steer you around the mountain? Both paths will get you. If you're on the left side of a mountain, you can go up and over it, or you can go around it. Going around it may be more distance, but going up and over it might be shorter. But when you're going over the mountain, maybe you won't make it up. And maybe if you make it to the top, maybe you can't control your descent. And is someone advising you? In their advice, are they telling you how good they are at justifying going up and over the mountain? Or are they telling you how to avoid the disasters of going over the mountain? There's different motivations to each. With increased technology, some things become more efficient, and some things become more convenient. When you look at the current standard, it says that it's possible that you don't have to do biocompatibility testing. And this is why I'm talking about the two different paths. You need to know what the two different paths are. If you've read the standard and you bid on that one sentence that says, I don't have to do testing, well, you need to read how much more you have to do to avoid the testing. This is with the onset of chemical characterization and toxicologic risk assessments to white paper justifying out of doing some of this biocompatibility testing. And it's a lot of work. It's a lot of chemistry work. And in reality, you might go through this process. It might take you 6 months. And the end result is that you can't answer the questions that need to be answered by testing. And now you're going to embark on testing, and you've run out of time. So as things have become more convenient, expectations have increased as well. And when has the government made anything easier? Sure, I can register my dog online now, but I still need the rabies certificate. I still need the vaccine. And so it's all the same amount of work. I just don't have to go there. So with chemical characterization, we didn't remove the tools from the toolbox. We just added another tool to the toolbox. So you're going to go full circle. The fact that you have some failed biocompatibility could be the result that you actually didn't realize you had to do it. And it's the same process. I don't have to do testing. Every day I'm on conference calls and people are trying to convince me that they don't have to do the testing. And I'm just the guy who provides the service. Meanwhile, they go on, and they get angry when we tell them how much sample we have. I will say that maybe we need 23 units. And that's an outrageous amount. And this typically is from the legacy products out there. There's products that have been on the market. Artificial breasts have been on the market since the 40s, and there was no biocomp testing done on them. And now there's a thing happening in Europe called the MDR, because of these artificial breasts that actually then started causing cancer. And they've made the situation in Europe where every product has to have testing done by 2020, April of 2020. So there's this big glut of people rushing to get testing done. And then you'll get into the bargaining. another lab told me I don't have to do it. Well, okay, like, it is really amazing to see. And so don't get stuck in angry denial. I'm just going to say that again, because, you know, if you put the testing up front, if you consider the questions that I posed to resolve the failure, if you ask those questions up front, then you actually are creating a plan to avoid that failure in the first place. There's a thing now called the biological evaluation plan, where, you know, the previous checkbox mentality is you took the grid and you did your tests and you filled out a form. Now what you're supposed to do is put this lengthy effort into the supply chain. Where did you get it? What's the catalog numbers? Was testing done on each individual component? Then chemistry. It's a big, long, arduous path that is now being suggested. Most surprise failures come from a result of a poor plan or no plan at all and a rush to test. Almost all the times that we deal with failures, it's that someone was in a rush for those results in the first place and that they just pulled the trigger. And I get it. You're in the final finished device conundrum. You're not supposed to do this testing on prototypes. You're supposed to do it on the final finished product. And you've got years and years invested in this, and now you have to do possibly a 6-month chronic toxicity study that's going to take 9 months to get results on. Meanwhile, products in boxes with IFUs, sterilized, waiting to go. We get it as the CROs, and we want to do our best to help you, but putting a good plan in place up front can avoid a lot of these failures. So I'd like to thank you. If you have any questions, you just need to speak up.
Hi, great talk. Gail Dad, I'm with FP Green, and I advise a lot of the kinds of companies that you're doing testing for, and they sometimes want us to help them find a CRO, a lab to do the testing. So this was really helpful and gave me a checklist of what to ask.
Okay.
One thing you said a couple of times is sometimes failures are coming up because the lab didn't know what the product was for. And is that intentional because you're supposed to be blind to that, or is that a failure of sort of part of the failure to plan process?
That's a really good question because the lab is supposed to know. When you read the GLPs, it does imply that the lab should be fully aware of what is there. But the reality is either people are too scared that the lab's going to steal the technology, or inform the competitor that you have something in the pipeline. But they're just sensitive to it. What we get is, we have a test request form, which is an order form, and you have to define what your test article is, and very frequently it is TR73. And with lot number A, or notebook 42, which means nothing to us, and that's really sort of keeping us in the dark. I can't tell you how many times I've had to make that phone call and say, we might have botched your study because now 6 months later, we can't find it in the rabbits, and them go, oh great, it's supposed to be absorbable. Well, that would have been good to know, because we thought we implanted it and then lost it, when in fact it did what it was supposed to do. It happens all too often. Right now, actually, yesterday and today, the FDA is actually at our facility being trained by us. And the FDA too is like unaware that most of the clients aren't informing the labs what the test article is. And I actually see that people may put more effort into ordering a pizza than they do with submitting for biocompatibility. I mean, it could be your company's, livelihood, and it's an order form. And if you have questions with it, call and ask and have it filled out. But there are definitely questions that need to be answered by the sponsor up front, which aren't. And then we get a call, or we have defaults in certain situations, like our default extract is 70 degrees. And that's because a good 50% of the time, that's not filled in. And we know from experience, most polymers, and most test articles are polymers, although that's changing now. Well, everything's a polymer, but when I say polymer, I mean plastics. Will withstand 70 degrees Celsius without degrading. All right? Oh, I'm sorry.
I have a question. How would you handle, hypothetically speaking, you receive, so you tested an article and you passed, and then your customer tells you that they also tested it at a different lab and it failed.
So I might need you to repeat the end of that. We tested it and it passed,
Yeah,
and something else failed?
yeah, so they say, well, we also tested it at a different lab.
Yeah.
And it failed there, so how, is that like, how do you handle that?
And that's a good question, too. And that's not a hypothetical question. That does happen. And that's actually, you could get in trouble with the FDA for doing that. So we tested it and it passed. The other lab tested it and it failed. The typical response would be, the typical action is that the sponsor probably would be angry with obviously the lab that failed it, and then demand answers from them. Or actually what happens is now they've lost, that this is their bargaining, they don't like that lab anymore, and they're gonna come to us. But what you shouldn't just take that, you need to find out why did it fail at that other lab. Is that I'm up here for Toxikon, and there are other labs, there's NAMSA, there's Wuxi. We're the top 3 labs. There are all sorts of little small startup labs. We're pushing through thousands and thousands of products a year, as are the others I just mentioned. But did you go to some new lab that started in Connecticut? Maybe they don't know what they're doing. And so it needs to be investigated as to why that failure happened. Maybe who knows, but it does need to be investigated. The extract is the single most important part of any medical device biocomp testing. It is, in the pharma realm, it is the drug. It is the dosing solution. And if the extract is done incorrectly, and another thing that happens frequently is testing was done 20 years ago. Can you certify that that testing's still good today? The first thing to look at was how was the extract done? Because although the standards haven't changed, the actual enforcement of the standard has. It has always said surface area is preferable, but in 2006, prior to 2006, people were using weight, or they were monkeying around with it, and some patients died. And when they investigated the biocomp results, they found that the extracts were really not appropriate. And so since then, they've really kicked to the extract. So that's the first place I would look, would be how were the extracts performed. All right. Thank you.